So, renal MRA. I haven't got my clicker. Here's my clicker. So first of all, a very brief history of renal magnetic resonance angiography. And as you can see there, it goes back a long way. And my name is even here, back in 1994, it's a long time ago. These are all non-contrast techniques, as we've heard originally. Most of the MRA techniques were without contrast. And these are the kind of images that we got. And most of the sensitivities and specificities that you see in these early papers are actually whether we saw the renal arteries or not whether they had disease or not. Okay? So we were considering it successful if we saw a renal artery. This kind of changed when we added contrast to the mix. All right, so as we've already heard today, possibly the first contrast-enhanced MRA published was from Leeds, and it was talking about the aortoiliacs, but if you look very closely at these images, I think you'll see that there are some renal arteries up here, hiding here somewhere. But the addition of gadolinium contrast to MRA made renal angiography a much more prevalent technique because we had much more success in seeing whether we had multiple renal arteries and comparing it to digital subtraction angiography, which was the gold standard at that time for this. This paper, 1997, showed 100% accuracy in 14 kidney donors. In fact, it was more accurate in that paper, in this small number of patients, than the intra-arterial DSA, because the intra-arterial DSA actually missed an accessory artery in one subject. And DSA, as I say, was the gold standard. And I think this illustrates well what MRA has got to match up to, because the problem with renal arteries is that they can be multiple, and the renal arteries can come off at funny places. So in this particular patient, we have an accessory artery arising from the iliac, common iliac segment down here. So you can't just have a volume that looks at this segment here. We have to interrogate the whole segment, particularly if we're thinking about access and doing an intervention on the renal arteries, because we have to image the iliac arteries to show the access. So I'm going to start with talking about normals, people who are walking around and feeling altruistic and decide they want to give one of their kidneys away. What kind of information do we need to determine if these subjects are able to give a kidney? We need to know more than just the number of arteries, because in fact, DSA is not a comprehensive tool for determining whether patients can give their kidneys, because we need to know how many kidneys there are, where the kidneys are. We need to know something about the kidney's drainage system as well as the arterial supply. We need to know whether there's any pathology in the kidneys that's going to stop us donating the kidney. We then need to know the arterial information, that's a given. But we need to know not just the number of the renal arteries and where they come from, but whether they've got early divisions and whether there's any intrinsic disease to the renal arteries. We need to know about the veins, and I'll talk about that a bit later. And really, ideally, we'd want to know about the differential function. So MRI can look at the kidneys, and we can look at them transversely or coronally. I quite like coronal in my protocols, but we can do whatever we want. We can do T1, T2, whatever. And we can find out where the kidneys are. And as I say, the kidneys sometimes hide in unusual places. So this is a patient with a pelvic kidney on the left side that you might not otherwise suspect. It's hiding away down here. So you have to have a large field of view to cover the whole of the abdomen and the pelvis. With 3D MRI, we can check renal size. So here is a post-contrast 3D fat-saturated T1, and we've got one kidney that's much bigger than the other kidney. And that's because that kidney has got an unusual variant. It's a kind of crossed-fused ectopia of the left kidney, and it's about twice the size of the right kidney. And there's a few little cysts and things in there as well. If you do a 3D interpolated T1 with isotropic voxels, then of course we could find the renal size, because the kidneys will not necessarily sit in the angle that you've imaged them at. So if we've got something we can reformat any way we want, we can image the kidneys in any way we want, we can reslice them in any way we want, and we can get an accurate length. Now what use is an accurate length of a kidney? Well, the reason we want to know the size of the kidneys is that in part it's a surrogate for function, and it's a surrogate, the length is a surrogate for the volume, both of these being surrogates for function. This is a paper published in JMRI back in 2002. This is looking at kidneys from pigs. So they had 8 pigs, sacrificed 8 pigs, got 16 kidneys. They imaged the kidneys in vivo prior to sacrifice, and they could show that there's a relationship between renal length and renal volume. So we did the same thing, except we didn't do it with pigs, we did it with human beings. We didn't sacrifice the human beings, but we did 3D T1, and we measured the renal volumes in a Cyrix, and then at the time of donor nephrectomy, when we took the kidneys out, so there's a kidney from a human, still in some red stuff, we took a piece of high-tech equipment, and we stuck the kidney into the high-tech equipment and saw how much volume was displaced from the saline in the bucket, and got the kidney volume, and we correlated that to the size that we'd got from the MRAngio. And we showed that there's a perfect correlation. There's a slight difference, there's a systematic difference, and that's because the kidney we measured in the bucket had bits of stuff hanging off it, like ureters and things like that, but otherwise it's the same thing. And as I say, we talk about the parenchyma, we can look to see whether the parenchyma is abnormal, and that's important because we don't want to take out a good kidney from a donor if we're going to leave them with a bad kidney. Nor do we want to take out a bad kidney and put that into somebody else. This is a potential renal donor that turned out to have renal lymphoma. It's a slightly funny picture, but we can see there's something wrong with these kidneys. Here's another one. This is an unusual one. This is a patient who had a previous acute tubular necrosis, and it's got a slightly unusual pattern on the T2. I'm going to talk about contrast-enhanced MRA because, as we've heard before, renal angiography with time of flight and phase contrast, these are old pictures, but obviously they demonstrate some of the problems we have with this, and I've alluded to that in the terms of the coverage. If you look in the literature, you will find some beautiful examples of non-contrast renal MRA. So this is from a recent paper in JMRI from Mitsu Miyazaki. But as the great Bob Edelman said, not only yesterday, NC-MRA techniques are often complex, inefficient, not standardized across vendors, and poorly validated. And that still plagues non-contrast renal MRA, in my opinion, which is why contrast-enhanced MRA is currently the standard that we use for renal MR angiography. So here is a standard renal MRA in a patient with 2 renal arteries on the right that would preclude them from donating the right kidney. Doesn't mean they can't give the left kidney, but it would preclude them from taking the right kidney. And just to show that's 3D, we'll move on. And just to show that this is vendor neutral in some respects, okay? So previous was vendor A, this is vendor B, but we can get just as good images from vendor A, B, C, or D, okay? This one is actually with Dixon, so this doesn't need a mask, this particular one, but we get the same from all of them. And we can show pathology, okay? So this is an unusual pathology you might not see very often. This is fibromuscular dysplasia, but it's a fibrointimal variant, which is a kind of subset of FMD. There are about 4 different types of FMD, and this is a subset called fibrointimal dysplasia, which is actually apparently very tricky to angioplasty, very fibrous. I'm going to talk a bit about spatial resolution, because this is important for imaging the renal arteries, because renal arteries are not very big. I got a reputation for imaging the renal arteries, and I was sent some of these from other places who couldn't understand why they weren't getting good renal MRAngio. And they were wondering why they couldn't see renal arteries that when they put a catheter up were obvious. And the obvious reason is that renal artery is there, but it's hiding away in here somewhere, and the spatial resolution and our contrast resolution is not good enough to see it. So here's another one from St Elsewhere in London, sent to me, and the reason that they can't see the renal artery as well as the DSA, and there's 2 renal arteries on the DSA, is on the DSA they've got a much smaller field of view, a much higher matrix, and an in-plane pixel size of 0.3, whereas on the MRA their in-plane resolution is 1.56 by 1.56 by 2. So they're not going to hope in hell of competing with that. You need higher spatial resolution. And again, it's not just spatial resolution, but it's something I'll call into in a moment, and that's motion. Okay, so you've got to compete with similar things. So for spatial resolution, I reckon you need at least 0.8 millimeter isotropic, 0.7 or 0.6 if you can get it. The difficulty, as we've heard of before, is this competing demands in MR of your acquisition time versus your spatial resolution versus your contrast resolution. So here's a patient, luckily not going for renal donation, but with multiple renal arteries, because again, this is the same one I showed you earlier with a kind of cross-fused ectopia on the left side. Breath holding, that's the other thing that bedevils renal MRA, in my opinion. This trade-off of spatial resolution and imaging time means that you've got to image during the breath hold. And the higher the resolution, the longer your imaging time is going to be, and patients don't hold their breath necessarily well. And the renal arteries and the aorta in the center when you breathe doesn't move very much. The proximal renal arteries also don't move very much. But if the kidneys move up and down, the peripheral renal arteries move up and down as well, and we get blurring. And that's what I'm trying to show with this movie here. This is someone holding their breath, and then after about 12 seconds, they stop holding their breath and the kidneys bounce up and down. So if your K-space, central contrast defining lines of K-space are in that period, or even some of your peripheral lines of K-space, you're going to get blurred renal arteries. So it's really important to practice the breath holding and have clear commands to the patient. And the clear commands have to be heard by the patient, which is why I moved in my protocols to using a timing bolus and not using fluoro triggering. Because if the gradients are humming and banging while the contrast is going in, the patient may not hear the clear breath hold commands. If you do a timing bolus, you know the gadolinium is going to arrive at 23 seconds or whatever it is, and you can have a nice quiet time in the magnet while you count down to that 23 seconds, and you get them to breathe in, breathe out, breathe in, breathe out, hold your breath at the right time. So here's an example of breath holding. This is not what I would call a good renal artery and MRA. You can see the proximal vessels are open, but we can't see anything else because the kidneys are blurred. The patient has not held their breath. Okay, this is the kind of the raw data from that, as it were. If we bring the patient back, this is the same patient, but coached in the breath holding using a timing bolus, and suddenly, ignore some of the noise in this, but we do get a much better image, okay? So it's all to do with breath holding and getting things nice and still. So we can see accessory arteries and we can see veins. This is actually veins on phase contrast and 2D time of flight from years and years ago. But this is more recently up to date with surgical. We audit our renal donor transplants in Glasgow, and we've shown that we can reliably tell the surgeons how many arteries there are and how many veins there are. And the veins are important because the one disaster I've had is in a patient who I correctly said that the renal arteries were okay, and at that point I wasn't really so fussed about the veins. I wasn't reporting them consistently to my chagrin. And the patient, the donor, not a patient, went to anaesthetic, and the recipient went to anaesthetic. They were both under GA. The right kidney was taken out. The number of arteries was correct. That was okay. But the right kidney turned out to have 6 renal veins. And that kidney ended up in the bucket, and that donor had lots of stitches put into his big blue IVC. And the recipient, who was expecting a kidney, obviously had to be woken up from anaesthetic and told they hadn't got a kidney, and the donor had to be woken up and told he'd given his kidney to the bucket and not to the patient. So that wasn't a good experience, and you have to report on the veins as well as the arteries. And you can have multiple arteries, and in my experience, multiple arteries often also actually goes along with multiple ureters, because when they're plumbing in a kidney, they want to put in the arteries and the veins. They've also got to plumb in the ureters, and they're not going to take out a kidney that's got 2 ureters. So whatever protocol we do, we've got to look at the arteries, the veins, and the ureters. And again, as I say, they're not going to take something like this even with a bifid renal collecting system. Here is another one. The arteries look okay, but we've got a retroaortic renal vein and something funny going on with that in the retroperitoneum. They're not going to take this kidney, so we don't want to tell them that the arteries are okay to take the left kidney, and then they run into trouble because the vein is there. Similarly, unsuspected, this is a potential donor. Unsuspected, the IVC is to the left of the aorta, and that's because the liver is on the left side and the spleen is on the right side. They've got situs inversus, which was not known about prior to this. Renal MRA became what I would call the 21st century medical IVU. If you just want to see the ureters, the only contrast you need is about a litre of pineapple juice, as the radiographers in Glasgow who know me know that we used to do this all the time. We just gave a litre of pineapple juice to the patients, made sure that they were nicely hydrated, and the pineapple juice has got manganese in it, and it suppresses the signal from the duodenum and the jejunum and everything, and we get a nice MRU. But we've walked away from that now because it's a bit of a chore for the patients, and in fact with some tuning of our post-contrast T1 fat sats, we tend to get nice GAD MRUs anyway, so we see the ureters. We just need to know how many ureters there are. It doesn't have to be a beautiful Rembrandt picture, but we can see the ureters on a post-GAD. And we're giving contrast anyway for the MRA. And sometimes we have to image several patients, so I'll say not patients, several donors. This is a husband and wife. This husband has got a relatively early division of the left renal artery that might preclude donating that kidney. The wife has got a duplex system on the other side. This is the world's first time-resolved breath-hold 3D contrast-enhanced MRA that I know of. And I say I know of it because this is the arterial phase. This is the later arterial phase where there's parenchymal enhancement. This is an even later phase where there's early venous enhancement. And this is later, and this is the first time, this is pure venous first pass without arterial. Okay, so this was me holding my breath for 40 seconds during an infusion of Omniscan. There's nothing wrong with me at all, nothing wrong with me at all. But it was the first implementation of contrast-enhanced MRA with parallel imaging. The people from Zurich, Sebastian Kazerka, came across and did this with us on our magnet at that time back in 1999. But it brings me on to the subject of perfusion. So we use renal perfusion now for our renal donor protocol. We take first-pass images, coronal and transverse. We use this basically as our timing scan. But it's not just a timing scan, it's a small dose of GAD, but we run it out to multiple times over about 3 minutes, and we can then, Rosario I think is in the audience, can spend some time, and we've shown as a poster at this conference about the fact that we can actually do single kidney GFR and differential functional estimations from these. So we do 3 coronal slices during the first pass of GAD contrast, plus the arterial input function from the transverse, and we can then do some fancy software analysis using some free software called PMI Button from Stephen Sobron in Leeds, and we can show that our renal donor kidneys, the differential function is the same as the isotope renograms that they're currently getting, and hopefully this year we will stop doing the isotope renograms and just have a one-stop shop for our renal donors. I have to mention renal arterial spin labeling because my name is on a few papers from this area. About it, I've been named, I helped Keith Giles. Keith Giles has done most of the work on this under Paddy Mark, Professor Paddy Mark as I should now call him, talking about ASL, but it really is remaining in the research domain, so I'm going to go over that. How about hypertension? What about hypertension? You don't need to know about the veins in hypertension, we need to know everything else, and we need to know what things look like. People say, why bother? The renal vascularization is dead, it was killed by Astral. Astral didn't kill renal vascularization, or it shouldn't have killed it, because you have to remember that Astral, as a study, you were excluded if your clinicians thought you would benefit from MRA, from renal revascularization, angioplasty and stent. You could only go in if they were uncertain as to whether you would benefit from it. And it did not include patients with fibromuscular dysplasia because they were specifically excluded, and hypertension was actually a secondary outcome. The primary outcome was renal failure. So we still image quite a few patients, particularly young patients, for hypertension looking for fibromuscular dysplasia. This is an example of fibromuscular dysplasia. This is real fibromuscular dysplasia. Some people call this fibromuscular dysplasia. I'm not sure this is fibromuscular dysplasia. I think this might be a standing wave effect in the renal arteries upon contrast injection. So we're never going to pick up something that subtle, I don't think, on MRA, but we can certainly pick up the former. This is an example of FMD, for example. This is a GP who'd been hypertensive for 20 years. When she was a medical student, she was known to be hypertensive, so they did an intravenous urogram, and that was normal, so she was reassured. But years later, she was sent by a hypertensionologist for FMD exclusion, and lo and behold, she had FMD, and these are the invasive angios showing the FMD, and she got some improvement with angioplasty, but not a huge amount because she'd been hypertensive for so long. Atherosclerotic renal artery stenosis certainly also causes hypertension. Here's a dark kidney on T2. It's less wet than the other kidney, and it's not getting as much blood as the other kidney. And this is an angioplasty and stent that I did, and the patient's blood pressure came down on the table. Similarly, this patient, atherosclerotic renal artery stenosis, a systolic blood pressure of 300 means that the blood pressure cuff doesn't go up any higher. These automated ones these days don't measure above 300. Smaller kidney on this side, but bilateral renal artery stenosis. With these images, we can tell exactly what angle of dangle we need for the intervention prior to doing it. And here it is. I did bilateral renal artery stents on this patient. Her blood pressure came down on the table. In fact, she felt rather unwell. Her blood pressure came down so far on the table. What I'm trying to promote here, though, is a comprehensive renal MRAngio. Do morphology. I mean, you could miss out this bit, in fact. Oh, go back. Sorry. You can miss out this bit if you believe you've got all the morphology on your post-GAD FATS at T1, but I like to do the morphology still. You can do a mask if you haven't got Dixon. If you've got M. Dixon, you don't need a mask. You can do perfusion for your timing scan. You can get your MRA, you can get your volumes off this, you can get your MRU with a tuned post-GAD. You can do it all with half or single-dose gadolinium contrast, as we were saying earlier. Keep the GAD contrast dose low. And a comprehensive examination shouldn't take you too long in the magnet. So I believe it still has a place. I think it's excellent for potential kidney donors. That's how we do all our patients in Glasgow. It's still got a place, I believe, in hypertension. Of course, we can see the adrenal glands because they live next to the kidneys. And I think that renovascular disease is more than luminology. And I think that's probably where Astral and Coral have gone wrong, in that they triaged the patients and they entered the patients based purely on luminology and looking at renal artery stenosis without looking at what the quality of the kidney was beyond that stenosis. If the kidney beyond the stenosis is no good to start with, then there was no point in doing the intervention. So thanks for your attention.
Thank you, Giles. Do you get one of these as the host?
Excellent. Thank you very much.
Thank you.